now we are delighted to have our first keynote talk this morning. It will be given by Dr. Anna Barnes to introduce her vision on AI in health and care. Anna is the director of the King's Technology Evaluation Center at King's College London. Now, welcome.
Right, anybody who wants to move from the back, do you want to just come down now? We want to make this nice and cosy if you change your mind. I always have to sit at the front because my eyesight's really bad, but do take the time to come down. Okay, first of all, thank you so much for asking me to come and talk. I was a little hesitant at first, wasn't I think? Because I thought, multimodal AI, because at the moment in healthcare, it isn't really multimodal at the moment. We're still taking very baby steps, and there isn't anything, despite what anybody says in the press, there is nothing clinically approved or used AI in healthcare at the moment. Anyway, let me tell you a little bit about myself so you understand where I'm coming from. I graduated with a physics degree in the early 90s, and then I decided I wanted to move into the medical application of essentially particle physics. So that takes you into the realm of imaging. And so I was an imaging physicist for a long, long time, and have hopped in and out of healthcare industry, academia. About 10 years ago now, I won a fellowship from the NIHR to do work on imaging biomarkers for cancer for a new multimodal scanner called PET MRI. And while I was doing this, I realized that actually it was very little about this amazing science and engineering that I was getting to use, and everything about the system into which I was deploying it. And that made me pivot in my career somewhat, so that I then moved into, originally, at first I went into a sort of management strategic post with NHS England within the Chief Scientist Office, and had to get out of there after a couple of years, because it's just, when you move into the civil service and you're dealing with governments, it's what can I say? I say things like mad as a box of frogs, but it's basically, it makes no sense. And as a scientist and engineer, that's really, really hard because nothing's rational. And then I was lucky enough to have the opportunity to go and become director of the King's Technology Evaluation Center, currently residing within the KCL School of Biomedical Engineering and Imaging Sciences. It had originally started in the NHS, actually at King's College Hospital about 40 years before, as K-Care, and had sort of transitioned along the way. And then round about the turn of the century, the National Institute of Health and Care Excellence decided they wanted to get into the world of cost effectiveness of medical devices. And at that point we were like, oh, hang on a second, do we really want to be doing, cost justification of CT scans and MRI scans and things? So some of the medical physics and clinical engineers stepped into that space, and we did lots of work for NICE for a long time. And then most recently, we had a big contract from NHS England to look at cost effectiveness of AI technology in healthcare. So I'm going to tell you quite a bit about that journey over sort of 4 or 5 years, and the things that we learnt, and things that I think will be useful for you to think about now. Can I just take a little straw poll? So who are still PhD students? Oh, lots of you. Okay, so listen, just sit and listen to this. It's going to sound like such a long way off, but I think if you start thinking like this now, you'll know when to take the next step. And maybe some of the stuff that has gone before has seemed a little bit abstract, a little bit like, oh, that's something that my director can worry about. So what I'm going to try and do is bring in some real world things that I think are tangible for you to latch onto. What about postdocs and PIs? Have we got any? Okay, a few. So come and talk to me afterwards, because I think you might be interested in some of the stuff I'm talking about. And is there anyone from industry here at all, apart from Peter? Yeah. Anyone else? Okay, so mainly academic. Anybody working in healthcare? Oh, great. Okay, fantastic. Okay, so I think this will be very relevant to you. Okay, so yes, so I'm at King's College London. We are in the department of the London Institute for Healthcare Engineering, and its director is Professor Seb Orsalan, who is very, very interested and passionate about being able to help his students and engineers translate their work into the real world. And so we have funding to run venture builders and med tech accelerators, of which we run, this is our second year cohort, and they learn everything there is that I'm going to tell you about now in order to help them on their way and decide what next steps to take. And most recently, I've just become the head of medical physics and clinical engineering at Guy's and St Thomas's. And so now I'm using a lot of contacts and things that I made during my work at KiTEC to accelerate the useful technology into making patients' lives better. Okay, so I'm going to tell you, I'm going to go straight in with some real-world stories. I'm going to tell you about some examples and how it went wrong, not necessarily connected to AI, and then things that you can avoid, ways of thinking to avoid those same mistakes. And then I'm going to get a little bit more into the practical side of things and talk to you about tools and frameworks that are available for translation and implementation. We're going to talk a little bit about methods for evidence generation and collection, and also to get you to think about who are you pitching to. Okay, so Hyping spoke about the grant that they're asking you to apply for, so that will be one, but then there'll be other, sort of, NICE or the Chief Finance Officer of the hospital. Okay, story number one. It's not just about clinical efficacy. Okay, so for decades, we do something called a bone scintigraphy or bone scan. The patient who will have this kind of scan is usually someone who unfortunately has been diagnosed with cancer, either breast cancer or prostate cancer. And it's highly likely that that disease spreads into the bones, and they develop what's called bone metastases, and it can be awfully painful. Once it's spread into the bones, it is terminal, but there are treatments to make that person's life better, and it's what we will call palliative care. So the trick is to know before the symptoms appear, or round about the same time as those symptoms appear, such as a sore back or a sore leg, to be able to say, okay, that patient's probably going to need second or third line treatment in a few weeks' time. And for decades now, we've used something where it's a technetium-labelled bone metabolite. Technetium is a single photon emitting radioisotope and used across many different type of diagnostic tests, being attached to different pharmaceuticals or metabolites for the body. As you can see, it's quite fuzzy. In most centres at the moment, it's what we call 1D or planar imaging. So basically, the patient lies down on the bed, they've had the injection of the radioisotope, radiopharmaceutical, and once it's distributed around the body, we sweep a gamma camera across the whole length of the body, and we can pick up areas. As you can see, there are some spots in the shoulder joints, the rib cage, and around the lower spine, where there's indication of higher metabolic activity, which is indicative of a tumour. And it's widely available. It's very easily done. It's cheap. And at the moment, it fits in well with the clinical treatment pathway. At the turn of the century, something called PET scanning came along. A few years after that, we joined it with CT, and then it became PET CT imaging, and a whole load of different tracers appropriate for medical imaging came along. And one of the most recent ones that's become more widely available, although there are lots of special ones out there that are being run in different radiopharmaceutical labs but aren't commonly available, is something called fluorinated prostate-specific membrane antigen. And very cleverly, the radiochemists were able to attach a fluorine-18 radioisotope in place of a carbon one, and attach it to this hormone that's released by the prostate. And of course, for any of you familiar with prostate, blood tests that show PSA levels, when they are increased, you've got to go and have more scans to check that, you know, if you've got prostate cancer or not. And so the first images were shown of this, and you can see straight away, and this is for the same patient, that there is a lot more going on than what the bone scan showed. The thing is, though, does it really matter? Is it worth it? As you can see, it's 15 times more expensive, it's not widely available, and the patient still has bone cancer or bone metastases. And so a lot of the clinicians, so the radiologists were like, oh, this is amazing, you can just see straight like that, speeds up everything, it's a much quicker scan, we can see more people, and it's really easy to read. But the clinicians, so that's the oncologists who are deciding whether to give the treatment or not, didn't know what to do with the information. So they would have people who would come for their routine follow-up scans to check how the cancer was progressing, and they lit up like a Christmas tree, but they didn't necessarily show any worse symptoms. And the decision then of whether to treat them became far more complicated, because these treatments are not nice. So if someone's feeling fairly well, do you want to start giving them chemotherapy or immunotherapy that really was not going to make them very well at all, and no specific data to show that it would increase their length of survival? And this is where we get into the outcomes research. So you think about all the wonderful radiochemists and the engineers and the physicists and the people doing all the reconstruction algorithms, and people like us, absolutely, you know, working their guts out to do this and making it work. And it's, you know, they did all the phase 1, the phase 2 trials, and it does exactly what it says on the tin. And then everybody went, nah, we're all right, actually. We'll just stick with what we know. I mean, incredibly disappointing. I'm going to go on to another example. Oh, yes, and then, sorry, yes. So you've been working in all this area on radiochemistry, and then guess what? One of your colleagues down the corridor goes, oh, yeah, no, forget all about that messy radioisotope stuff. We can do it with MRI. Special sequence that can run. No messy radioisotope. Yeah, okay, it takes quite a long time, but, you know, much nicer, much better. So what I'm saying here is that you've got to step outside your zone of knowledge, your expertise, and suddenly become an expert in a different field in order to understand the impact of the system that you're introducing it into. Here's another example. This is one of the ones we worked on with NHS England. This one is an AI algorithm. It's sort of image lesion detection thing. So this is a single modal modality technique. So it takes CT images and can automatically detect whether or not there's a hairline vertebral compression fracture. Okay, so let me set the scene a little bit. So the company had spun out of a university, and they developed this algorithm based on CT images of the spine, and were able to show that it had really high accuracy, sensitivity, specificity of being able to detect these lesions. But then they realized they didn't have a use for it. So they teamed up with some consultants in healthcare, primarily someone who was interested in bone disease, osteoporosis, bone thinning diseases. And he said, oh, I think I've got a really good idea. So we're quite often getting people who suffer from osteoporosis after they've had their first fracture. It would be really great if we could detect them earlier. Great idea, part of the government initiative for prevention. And he also knew from colleagues that we do, that the highest volume of scans that we do is a CT of abdo-pelvis, chest abdo-pelvis, okay? It's one of the things that loads and loads of patients have. They come in through AI, they don't really know what's wrong with them, fine, just send them off to get chest abdo-pelvis CT for other reasons. And so he said, right, well, if we just run this AI algorithm over all these scans that come in, we'll be able to pick up a whole load more asymptomatic hairline fractures, and then we can start treating them earlier, and then that will stop them becoming crippled, etc., etc. Great idea, absolutely, totally sound. NIHR loved it, gave them loads of money to do it. However, what they weren't familiar with at all was the system into which they were deploying it, and that was the radiology system. So this doctor worked in metabolism and osteoporosis, didn't know anything about imaging really other than this idea, and that he would often refer patients for imaging, but didn't really know how the radiology systems worked in his hospital. So we worked with them for a while, and it turns out what they hadn't done was gone out to all the different radiology departments and found out what they do now for incidental or opportunistic findings. So I think Haiping mentioned about baseline measures, okay? So what they hadn't done was gone out and found out, you know, will this sit in the way you work at the moment? And this is really important, because what the company and he was asking people to do was for the radiology department to completely change the way they work and to pay for this to be deployed in their system so that he could get the benefit from it. And this is where it starts getting really complicated, and you have to start thinking about symptoms. The other thing that he had said in his application was that he suspected there was about 30% of people walking around with fractures that didn't know they had them, and so that there was potentially a sort of 15 to 20% increase in patients who would then get treated. The treatment pathway is that you detect a fracture and then you get referred to a fracture liaison clinic and you get treated. And sometimes it might be increased vitamin D or calcium tablets, but more often than not, it was self-care. Make sure that you go to the gym, you don't eat too much, you don't, you know, put on too much weight, etc., etc. So the first thing that we realised were there are not enough fracture clinics now, and all of them have got a very long waiting list. So like, we're just going to add to the waiting list with, again, no clear definitive data on whether it's really going to make a difference. And I mean just both in the difference to the patient themselves, knowing earlier than they would have done anyway, but also to the cost borne by the health system itself, who have to treat these people who have mobility issues due to osteoporosis. So it hasn't really gone anywhere. So again, lots of money invested, but actually got to the end and went, actually, I don't think this is going to work right now. How disappointing, you know. And it's not because the AI isn't good. The AI does exactly what it should do, and is very robust, in fact. So all the things about bias and where you get the training data from, and, you know, differences in CT scanners and all that kind of stuff, it works really, really well. But the use case isn't there, or at least the way we work, it doesn't fit in. That's not to say that it might not work brilliantly in the US healthcare system or one of the other countries, but here in the UK, it wasn't cost effective. So that's some things that went wrong. So I hope that doesn't sound too depressing, because these are two really excellent pieces of technology that just haven't made it into wider healthcare use, and not because they're not good. Why? Well, I think hopefully you've already realised, as Bill Clinton said, it's all about the economy, stupid. These are just splashes up of when you think about introducing something into healthcare, you are effectively introducing it into a complex system. Okay, so those of you who know about the mathematics of complex systems, start thinking graph network theory, systems engineering, etc., and emerging properties from networks. And I've just left this definition up here so you understand why complex systems are appropriate to healthcare. So you can swap out, you know, business. I mean, the NHS, a hospital is not really a business, but sometimes it's sort of run like a business, and I'll go on and explain a little bit about that. There's a link down here that if we have enough time, I'll go back and play it. It's a little animation cartoon from the King's Fund to explain to you who pays in the NHS. But all is not lost. It's okay, because there are lots of frameworks and guidance out there that will help you step through everything that you need to do. The ones in purple are, if you log on to the, well, you don't need to log in actually, if you just Google NICE, the National Institute of Health and Care Excellence, and type in Evidence Standards Framework for Digital Healthcare Technologies, it will bring up a whole load of information, and it explains to you the dimensions with which it evaluates the technology that it needs to. So you can see here it's about describing value, deployment considerations, delivering value, demonstrating performance, you know, some usual things. And then within that, it's got 21 different standards. To the other side of the screen in the blue, this is just explaining whether or not your software is a medical device, and that can include AI, obviously, whether it's, instead of using class 1, class 2A, B, and class 3, we've got these different ones about tier 1, tier 2, and tier 3, and it's about what is the influence of this on the patient treatment management. So I think it's the way of... so the lowest tier is just when you're improving productivity and workflow, and the highest tier is when you're actually helping the doctor make decisions about what happens to that patient. The one in the middle is actually a systems engineering tool developed by the University of Cambridge, which I'll go into a bit more detail, to help step you through, originally developed from inception of an idea to the final design, prototype, for instance, of your technology, but can you be used at any point in the translation stage? And then the ones in the white boxes are what NHS England want you to evaluate the AI technology against. So that was the 7 domains that we had to work to when I was doing the AI evaluation the last 4 or 5 years. And then, of course, the NIHR have lots of funding streams around introducing medical technology into healthcare, not least of which is the health technology assessment funding theme. So going into a little bit more detail, if you have a look at the evidence standards framework, so I put this here just because there's a lot there, not necessarily because I want you to read it, but if you go onto the website, you can click on each of these links and they'll go into a lot of detail about what kind of evidence they need you to provide. And if you take the time to read it and map out what you've done already onto the evidence here, you'll see that while you've done a lot of work on performance, you won't have done any work on whether or not it fits in the system or whether or not it's cost effective and is actually making a measurable, demonstrable impact on the system as a whole or any patient outcomes, because that bit's difficult. Suffice to say, they are working on this. It doesn't always stay the same. This is because it originally came out of all the drug evaluation studies that they do, and we're very familiar, I think, on the UK news. NICE has yet again not approved a particular cancer drug because it's not cost effective and doesn't show measurable health outcomes across a wide enough of people. They've tried to apply the same thing to medical technologies. It doesn't quite fit, and I'll go on and tell a little bit why, but it's still a valid question to ask, because remember, when you're talking about a publicly funded health service, it's about who can gain the biggest benefit and as to as many people as possible. And that's the nub of why something can be absolutely brilliantly science idea and technology and engineering, but it's too niche or it's too expensive and doesn't provide enough bang for its buck, is one way to describe it. So that's a lot of words. I prefer pictures, which is why I ended up following the University of Cambridge work on engineering for better healthcare or improving improvement. It's called the II Toolkit. You can download it for free. It has a great quick user guide, which will keep you going. But essentially, it encourages you to think about, and I think Haiping mentioned this earlier on, from beginning to end. Now, the beginning to end could be a piece of it, or it can be literally from the beginning to the end. So from your idea all the way to the patient getting their healthcare. And And the idea is it's an iterative process. That's what I mean about you can do it at every single stage in the translation pipeline. And you keep asking the same questions over and over again until you've proven to yourself that the system as a whole has been improved. This can be boiled down into 6 steps described there. When I work with teams who've got a new piece of technology, I warn them that they are going to spend at least 6 to 12 months with me working on the first 3, which is the solution, the problem, and the context. Now, of course, they'll say to me, but we already have the solution. And I said, yes, but have you really well defined the problem that you're solving? And it turns out oftentimes there are several different problems that they could be solving depending on which audience they're speaking to, which is great, okay? Because if you can cover all the bases, there's better acceptance into the system of what it is you're trying to do. So we help them reframe that. And that's because we do a lot of work in understanding the context. And this is where we get into this idea of multidisciplinary teams, bringing multidisciplinary types of research into the development project. So a lot of you will million miles away from things like qualitative research or behavioural change. I'm telling you now, get to grips with it, because it is the nub of people adopting your way of thinking and your way of doing things. And there's lots of really interesting stuff about understanding complex systems, behavioural change, and organisational restructuring in order to cope with new technologies. And unfortunately, the NHS, well, like all of us, we're quite resistant to change, but the NHS in particular is very resistant to change because of all the people that it involves. And they all have different motivations and different skill sets and different ideas, different mindsets. The other thing you do is, as I pointed out in the first slide, about how you might know everything there is about your field, but actually what you didn't know was there is a completely different diagnostic pathway to get to the same point. And what happens is that each healthcare system will choose the thing that's easiest for them to do. So that's why I pointed out to you about the bone scintigraphy, which is really easy, very cheap. Everyone's got a gamma camera out there now, even the remotest district general hospitals, whereas only a few of the big teaching hospitals have PET-CT. So it's about understanding the environmental context, physical context that you're going into, but also in terms of what else is out there at the moment. So I like this framework. It's very visual, and it's good. I can have it up there all the time, and I just keep going back. When I feel a bit lost amongst the woods, I can go back and remind myself where I am. Another framework is from UCL. Susan Mikey, I don't know if you remember her, she spoke a lot during the COVID pandemic. She was very instrumental with working with her other scientific colleagues about behaviour, understanding behaviour of communities and how they would react to things. So this is a really good one as well. So if you team up with your qualitative researchers, this is what they'll be working to, and they'll use things like human factors is an all-encompassing talk about this, and can also, so human factors is interesting because it both involves the behavioural side of things, but also ergonomic, structural, physical design around, things like, you get the computer mice, for instance, that have been designed so they sit nice in your hand. So that's one part of human factors. Another one might be number of clicks on the screen, but also it's about, how do you do your day? Do you come in first thing in the morning? Do you prefer to do things at night? All that kind of stuff. So these are also snapshots from the University of Cambridge toolkit. And as you can see, it's sort of got, it takes you through, you've got questions and then you've got activities. And so again, I like this because it's a bit of a recipe. So you've got things like, so in the context bit, which I get people to spend a lot of time in, is you start asking questions. What's the purpose? What are the needs? Who are the stakeholders? I mean, these questions will go on and on and on depending on what crowd of people you're talking to. And then you actually have tasks. So you've got to create a stakeholder map. You've got to have someone who's going to generate the different scenarios in which your technology is going to get used. You might have someone who goes in for the day and watches how the nurses or the technicians use what they're doing already, and so on and so forth. This is a big piece of work, right? It's a big piece of work, and it costs money. No one's that willing to pay for it at the moment, but there are these pockets going on. So what's interesting is you'll find a whole load of qualitative researchers who've been doing stuff. They might not necessarily be linked to a particular engineering technology, but you can still go and talk to them and use a lot of what they've already done. So that thing you said about looking at what you've already got. So that's another thing that a researcher can do for you, is going out there and have a really wide search on things that can link to or be part of your knowledge gathering exercise. Yes, and things like focus groups and structured interviews. Now, there's a big thing on patient and public involvement that the NIHR and a lot of grant funding bodies push now, but I would argue that actually your users, so that's the staff in the hospital who are going to be using your technology, are also part of that group, and that's what is referred to as stakeholders. So make sure that you have spoken to everybody, not the flashy medic that's come to you and said, I've got this great idea, but all the other people around him or her who make everything work. So that's qualitative research for you. Okay. Now we get into, I guess, sort of a space that maybe you're a little bit more comfortable with, which is what you probably did at the beginning of your PhD. You might not have done a systematic review, but you probably would have done a targeted literature search. And then initially you would have started off with thousands of papers and then worked with your supervisor to hone down into the ones that you really need to look at, and you're going to then launch your own research from. But what you can do for health technology research, or evaluation, I should say, for a group like myself, is we go out there and look for evidence that's already been generated, either by something similar, or if there isn't anything similar, whatever the standard of care is. And that often has to be done in a more systematic way. So the difference between targeted and systematic is that, of course, it's reproducible and transparent to anyone else who wants to do it. So the idea is that you would sit as a group, you'd ask the right question, and there can be several questions, but you hone in on one of them and you build your Boolean logic query and run that through your various different literature databases, and then you have a team that sit down and you go through all of the papers and you finally whittle it down. It usually comes down to about 5 or 6 papers that have got the actual data that you need, because of course when we're doing our own, when we publish our own work, we put in what we want people to know about, which isn't always the same as someone else. And so what you're trying to do at this point is look at, be able to compare like-for-like studies. And of course, everyone does things slightly differently. So that's why you end up with not very many in the end. And that's what's really challenging, because what you would do afterwards is you do a meta-analysis. I don't know how many of you are that familiar with statistics, but you can take all of those single statistics and do sort of a population-based statistic based on those effect sizes that have been published. And it's frustrating because, as I said, usually things are not similar enough, and so you end up with 5 or 6 studies that you can do, and then usually invariably it doesn't show any useful effect at all. But this is this comes under what's called data extraction and data synthesis. Okay, it's not so much that we're creating synthetic data as that we are extracting data and putting it together as a new body of evidence collectively. And the reason I'm telling you about this is because it's about quality of evidence. So again, depending on who it is that you're talking to, that you're pitching to, they will have certain criteria about how reliable and robust they want that data to be. So for drug trials, for NICE, they always want randomized controlled trials, always. And if you haven't done one, or there isn't enough, they won't even consider it. As I said, with medical technologies or medical devices, this is not quite the right thing that you want to do, especially when you start going into the real world data. And NICE are beginning to realise that now. So while you've got meta-analysis, which of course when you're at this stage there won't be any anyway because you're still designing it, the randomised control trials and non-randomised control trials are now at an equal setting. So non-randomized controlled trials will include things like observational studies. So you've put your technology into the real world, and then you start gathering the data from all the different centres that you've used without randomizing the centre or randomizing the patient. Yes, so those of you who aren't familiar with systematic reviews, there's your little flow diagram. But as I said, you usually start off with thousands, and then it whittles down to sort of 5 or 6. Okay, so now I'm going to move on to hopefully an area that you should be fairly familiar with. And if you're not, as an AI specialist, I suggest you get your head stuck around multivariate statistics pretty rapidly, because that's where it all started. So, differences between randomized controlled trials and real-world data. So the reason I'm talking to you about this is because by this point, I've only got 5 minutes left. I'm only halfway through. That you've been working with the team, and now you've understood all of your context. So now you're going to build into your model all of those different things of context. Okay? And here there is the pros and cons of randomized controlled trials versus real-world data. So the thing about randomized controlled trials is that you're completely controlling everything, and that's not the real world. So you've done it on a particular group of patients in a particular hospital, even if you've done it in several hospitals, and it's too controlled. But that's the bit where you show that the efficacy bit. Okay, that's the efficacy bit. That's showing you that the performance works in a particular group of patients. That's great. But then actually when you want to go into the next things that people are interested in, which is about feasibility of scale-up, appropriateness of scale-up, and fit with site, you really have to start looking at real-world data. And of course, you're then in a bit of a catch-22, because you've got to try and get someone to adopt your method without there necessarily being published randomized controlled trial data. And that's when it starts getting a bit more outside the science and much more into behavioural context. So I've just put an example up here of a sort of a linear mixed effects model, but things like latent variable modelling, principal components analysis, independent components analysis, actually loads of work on multimodal multivariate statistics and latent variable modelling has been done. That's about 10 years ago. Go back and have a look at what they've done if you want to start doing multimodal AI. So these are all the things you have to think about. So again, remember, don't just rely on that one healthcare professional, because it's very likely they won't know at all of the nuances within the system. So make sure that you speak to as many different people as possible, healthcare professionals, and that includes from the admin team all the way up to the finance officer at the hospital. And even people outside of the system or the clinical pathway, but are actually part of the infrastructure of the hospital, like estates management, IT teams, other clinical professionals like your clinical engineers and healthcare scientists, of which I am one. This is called process evaluation, and there are some interesting frameworks published out of some of the NICE health assessment teams. So why are you doing all this? Well, you have to do all of this before you can even begin to think about doing health economic evaluation. So don't think that you sort of go, oh yeah, we've got to do something about health economic evaluation. Right, I'll just employ someone. Because I'll give them a few grand to go away and do it. Because of course they have to do all of that stuff that I've just shown you in order to be able to build a model. Remember, it's about building the model and then putting the data in. And we're all familiar with that building the model thing, because we're all engineers and scientists. So in order for the health economists to do what they want to do, they have to know all of that I've just spoken about in order to build their model. And then they can go about collecting the data. So there are different types of cost analysis you can do from a health economic model. Budget impact, cost consequence, and cost utility. The hardest one is cost utility. You can get sort of halfway there by doing what's called cost effectiveness, but cost utility uses something called a QALY, quality of life adjusted years. So that's how NICE like to define their thresholds of whether or not they're going to pay for something. And again, I don't think it's particularly appropriate for medical devices. But cost consequence can use different, is really basically how much is it going to cost the hospital to implement this? And you don't need to worry about the health outcomes, but just look at how much capital outlay and how much maintenance costs. A model will have something like either, so you can see how the systems engineering pathway analysis, so you'll be able to talk to a health economist, right? You talk the same language, it's just a different context. Things like dynamic causal modelling. But you can also start off somewhere really simple with a decision tree modelling, and then you just put in, you know, the pathway which the patient goes down, and then the percentage of patients that go down that pathway, and the costs, et cetera, et cetera. And like with anything that you're doing, you then get uncertainty in this system. And this is another place where everybody falls down, because we're all really different. There's no one size fits all. And despite what the NHS might have you think, every single service or every single hospital I've ever worked in does things differently from the last one. So here's an example of, say, an engineering type thing. So you're building, I guess this was some sort of metal spring, there are all the different things that will, parameters of that metal that will tell you something about the uncertainty of its performance. You can do the same thing with project management. So here's all the costs, okay? All the types of things. And here's an example of the same thing for healthcare, okay? So again, that uncertainty that you're very used to measuring in your system on very, you know, sort of failure rates of components and things you can use for exactly the same thing when it goes into a system. And your failure rates or otherwise are on these particular important parameters that your health economist and your statistician will have worked with you to find out what they are. And then you get into the whole, so basically what you want is B will be the threshold at which NICE will pay, and then you'll plot your cloud around the uncertainties to show that most of the stuff falls below the cost, and that's great, and they want to adopt it, and here's the willingness to pay. Finally, you will write this all into a report, which we call the Health Technology Assessment Report, and here's an example of templates that you can download. Okay, I'm going to whiz through the next, but I just wanted to let you know that there are groups called NIHR evidence synthesis groups. There's the link there. They're all around the country, and they publish things like this that will be helpful for you to talk to them. And they understand it's not global health, it's not health economics for big populations. And you'll probably recognise some of those things. Yeah, Sheffield, of course, has got a huge excellent team there. So there are people who you can reach out to who will help you do this. You don't need to do it on your own, although you're all perfectly capable of doing it. And some of you might decide you want to go in that direction like I have. But there are people out there who can do it. And then I just wanted to finally touch on who's going to pay. Okay, so it might be patients and carers. You might just develop something and then throw it out there into the public. Why not? Loads of other people do. It definitely won't be these guys who are running at the front end. Okay, we're not in charge of our money. But you will be working with them to get that user feedback. The people who decide what's going to get funded, so that's, of course, the National Health Service and the Integrated Care Boards. That's why I put that up there. And they're going to get, so there's loads and loads of them, 40, but I think they're going to get subsumed into just 7 now, I think. They also don't pay. National Institute for Health and Care Excellence, who are the regulators, okay? So you go to them and you say, I want you to show that you get the bang for the buck. It is definitely worth it to adopt my technology. They also don't pay. They also don't have any money to do the evaluation. You have to pay to do the evaluation. The Chief Finance Officer, that's the person who pays. Right? So whoever is in charge of the money in whichever level you're talking to, so that could be the GP practice, the hospital, the community care officer, the person who runs the care home, that is it. And they will say to you, is it in the budget? If it's not in the budget, they cannot buy it, which means that you always have to be cognizant of when those budget deadlines are. So usually business cases get made in the December. They have to be finished in the December before the new start of April in the tax year. That's me. I've done. Sorry, I overran. Come and chat to me later.
Thank you very much to Anna for giving a so excellent talk. Now we are the Q&A time. Any questions?
Hi, thank you for such a great talk. So going back to your talk about like the technical efficacy part.
Yeah.
So like I know as like AI researchers, we typically like to focus on things like the ground truth. So I read this really great paper about like deep learning in radiology scans that kind of was like when my peers were reading it, like one big takeaway we had was like our ground truth was like the radiologist's decision of whether or not this was like, you know, had cancer or not. But then they were talking about like, oh, why don't we actually compare it to like whether or not the patient actually had cancer? And so like in terms of like thinking about time as a resource as well, like within the healthcare industry, do we care more about like how speedily we can deploy something or like whether or not we can actually improve upon like the kind of accuracy rate?
Yeah, no, I mean, this is an excellent question and is what I spend most of my time thinking about. So what I would say is that it's always been thus with software as a medical device. I've worked for years. I mean, most of my papers were published in using traditional statistics to help with diagnosis and reporting, et cetera, of images and image analysis. So what I would say is this is where the bit that everyone talks about is accessibility of data. The NHS is sitting on an absolute gold mine. The trouble is it's not curated, it's not joined up, and we can't access it. So what you ideally want to do is have the ground truth data, which is the radiology report plus the clinical follow-up data. So you have to be able to get hold of previous data. So that's the first thing you need to do, okay? Now, one of the things we had trouble with was looking at screening, so AI and breast screening in particular, where I think it's only something like 8 out of 1,000 images will be reported as positive, and out of that, maybe only 5 will have a positive biopsy result. And that's been based on years and years of looking at data. So that's sort of, in cases like that, that's your ground truth, okay? So if you're detecting, so if you take your population and you're able to detect from a whole load of data roughly about that number of positive cases, then you're as good as a radiologist, right? So that's where loads of people come in. It's like, am I as good as the radiologist? Because there's a trust thing here, right? So if the radiologist knows that it's giving the same answer as they would probably give, they're happy with that, regardless of whether or not they were right. Okay, and I worked for years with my radiologist colleagues, and what would happen when they were using my software that I'd built is that they would be very happy if the software agreed, and if the software didn't agree, they ignored it. So that's an audience that you're trying to convince there. For NICE, who are saying whether or not NHS should pay for it, then it's a different thing. It's all about the outcomes. So in that case, it might be that because it's as good as the radiologist, you can remove a radiologist. So at the moment, the screening is 2 radiologists have to read it. The idea would be if you could take away one of those and just let the machine read it plus a human, because we always have human in the loop, then you're saving a salary, okay? Bonus, if it then detects more lesions, okay? But to do that, you have to do follow-up. Now, there have been studies out there who are doing follow-up. So we get scanned every 3 years, so you can do that, okay? The other thing you can do is you can actually pay to make sure that anybody who does have a biopsy follow-up is part of your study that they're followed. This starts getting expensive now, okay? Because then you're getting into the world of randomized clinical control trials kind of thing. The other thing you can do is use it in a different context. So some of the other stuff we've done is in a breast symptomatic clinic, where you're going to get a higher prevalence of people with lesions and positive biopsies because they're going there because they felt a lump, right? So probably about 30% of the people who go have a detectable lump on mammogram. So it's a completely valid question. But what I would say is that I think as developers of AI algorithm, you've got things, you can work with synthetic data, right? Then you can start working on retrospective data. Then you start working on not only retrospective data, but retrospective data from all sorts of different sources. So you're putting that natural variance in as well. And then you've got to the point where you go for your CE marking, because it does what it says on the tin. And be careful about what you get your CE marking for. Don't go out there straight away saying, oh, it's all about diagnosing breast cancer. Have something very general like lesion detection in mammography or something, okay? And then you go out there and you say, I've got a CE mark, I want to now start doing real world. And then you get into that sort of marketing world, which is, okay, we've done these, we've worked with clinicians, we've done this stuff, and now we can say that if you want to use it for this, this is the data we've got. But it's different from the drugs, because as soon as you've got your CE mark, everyone can buy it, okay? So if you do find someone who's got money, they can buy it. They don't need to go through regulators, okay? So I hope that's a very long-winded way of answering a question, but I hope I've given you some useful info there. Is it
Thank
time?
you. And we see the second question is here. Can our volunteer to give the... Oh.
Thank you. Thank you so much. This was so interesting. I was wondering if you could tell us a little bit more about maybe blue sky research, if you want to call it that, in contrast with this very functional and very, and for which there's such a well-defined framework to assess costs. I was thinking about your initial story about bone metastasis detection and how all the whether that was not an excuse for all these radiotherapy and all this imaging development that then had broader uses down the line. And in particular, if you could comment on how different funders will be interested in these different aspects of research outputs.
Yeah, another excellent question there. Yes, so I suppose where I sit might be not quite blue sky, because it's usually around the fact that there's been a clinical need and someone's read an interesting article in Science or The New Scientist or something, and they've gone, oh, I wonder if that will work for healthcare. So there's that side of things. With a radiochemist, of course, if you're a radiochemist, your holy grail is being able to design that radioactive molecule that mimics something biological. And so you'll spend all of your time looking at, I mean, of course, you can have AI now in that field as well. And then you design your molecule and you're like, right, who wants to use it? So what I would say is that there are funders who will absolutely fund that part of the research, but I think it is also, they're asking more and more now about where that might go. And it doesn't need to be, I don't think they're asking for it to be completely detailed. I think they just want you to give a nod that you have actually thought about it. You have actually thought about who might be using it. I do get a bit annoyed when they're sort of insistent on some of the really esoteric stuff that has to have patient or public involvement, because it then becomes a tick box exercise. So I don't know, you might run an open evening on, this is what we're doing at the moment, are you interested? That's okay. But I suppose you could run something a little bit more focused and say to patients, okay, I'm going to explain to you how this works. Tell me all the things that it could possibly be used for, right? That's kind of an interesting thing you could do that will help you write a grant, I suppose. But I don't stop doing the blue sky stuff. Absolutely not. But it's about having people in your world who can join the dots. And sometimes it'll be, so when I was much earlier researcher, I was completely consumed with what I was interested in doing, which was brain functional mapping. Now that I'm a lot older and I've done lots of different jobs, I find it much easier to listen to a PhD student and go, oh, I think I know where that can sit. And I'll, connect things up. So us old duffers are useful for some things, even if it's just our real world experience about where to go with it. So yeah, keep doing the blue sky there and look out for the right funder, right? So I think, for instance, MRC stepped away from doing any real world stuff and went right back to the bench quite recently, which was an interesting development, whereas NIHR, of course, are right down the other end.
Thank you very much. But because of the very limited time, we have to stop the Q&A here. And you are more than welcome to talk to Anna in
Yes.
the coffee break.
Yes,
Sorry about that.
of course.
And
Thanks so much for
now
listening.
we thanks Anna again.